Hello everyone, my name is José Carlos Martins da Rosa. I am the developer of the immediate dentoalveolar restoration technique. Everybody knows that this technique is a paradigm shift in the treatment of compromised sockets in the static zone. That's why I would like to invite you to come with me in this travel to modern implantology. IDR is a bone grafting at the time of immediate implant placement and provisionalization in compromised alveolar sockets, always using graft from maxillary tuberosity. This technique is based on biological response. Our goal is the preservation and regeneration of the natural biology. This was our first IDR clinical case. As you can see in the upper right central incisor, we have the presence of the infection, total loss of the buccal bone wall, and the fracture. So to summarize, what is the main goal of the IDR technique? In the protocol, we perform the tooth extraction, apply minimally invasive procedures, we install the implant in the correct dimensional position, and we start the bone reconstruction first using corticocancellous block bone graft to restore the wall that the patient lost, plus particulate bone as a bone filler. Both grafts harvest from the maxillary tuberosity. We made our provisional restoration immediately, and 3 months later we have the maintenance of the anatomical contour of soft tissue. And here you see after we deliver the final porcelain restoration. And here the follow-up after 17 years. I want to call your attention to the new buccal wall, completely remodeled and is still stable, but better than that. And you see here the maintenance of the gingival architecture position exactly in its original position. No other technique available in the literature can allow you to get an outcomes like this. IDR today is fully digital from planning, surgery, and the follow-up. Look at this case. The hopeless tooth was the upper left central incisor. It was missing the buccal wall, and this patient had a thin periodontal biotype. We did the digital planning to insert my implant in the correct dimensional position. I used the guided surgery. It was performed here the bone reconstruction using bone from the maxillary tuberosity, and we installed immediately my milled provisional restoration. And after 3 months, we have the relevant change in the soft tissue quality and thickness without any connective tissue graft. So we did the scanning, we did the final porcelain restoration with ideal emergence profile, and you see here the follow-up after 2 years. Everything is being maintained in the right position. So we have here the balance between the lips, the gingival architecture, and the final porcelain restoration. So what aesthetic outcomes do patients want today? To mimic the nature. If the patient lost the wall, our goal is to replace the wall that the patient lost with the new biological wall. That means we are going to use bone graft, corticocancellous graft harvest from the maxillary tuberosity. This is the immediate dentoalveolar restoration concept. This is a minimally invasive approach. This is a flapless surgery, but all credits go to the mother nature. We take advantages on bone biology. We harvest bone graft from the maxillary tuberosity using chisels, like handle instruments, and we reshape the graft according to the defect configuration, and we insert the block bone graft first to restore the wall plus particulate bone as a bone filler, and immediately after we finish this task, I install my provisional restoration. Let's have a look at the main IDR protocol in the management of compromised sockets using corticocancellous graft. This patient had a problem in the upper right central incisor. You still have the gingival margin in the same level of the opposite side. The condemned tooth was the right side, the right central incisor. The patient lost completely the buccal wall, and we performed a minimally invasive dental extraction. We confirmed the loss of the buccal wall, pressing the periodontal probe at the facial aspect. The implant was placed in the correct three-dimensional position, always respecting a gap around 3 millimeters at the buccal aspect. And we did my provisional restoration. We checked this provisional restoration onto the implant, and we left what we call a soft tissue gap, an under contour at the buccal and the proximal aspects. To harvest bone graft from the maxillary tuberosity, we need previously a clinical assessment and X-ray and a CBCT from this donor side. As soon as the flap is raised, we use chisels, and the chisel has to be placed as perpendicular as possible to the bone structure right after to go deepen approximately 2 or 3 millimeters. We can go until the planar length, and we fracture the bone. This is the block bone. We reshape the graft according to the configurations of the defect, and we also match the corneal part of the graft with the outline of the gingival margin in order to restore the bone architecture. We harvest more bone from the tuberosity to be used as a bone filler, and we fully fill these gaps with particulate bone. And you can see here that the implant was placed at 3 millimeters from gingival margin and the bone graft 1 millimeter above the head of the implant. We install the provisional restoration immediately out of occlusion. And here you can see the corneal displacement of soft tissue. So we didn't remove this provisional restoration for 3 months, and after 3 months, to push up the soft tissue in the apical direction, we added composite resin 0.5 millimeters a week for 2 or 3 weeks in order to balance the gingival margin position with the opposite side. As soon as we finish this task, you can see this image in the right side that the papilla is being maintained is in its original position, and we have a maintenance of the volume of soft tissue at the buccal aspect. This is the final abutment, the zirconia abutment in place, and as soon as we deliver it and we cemented the porcelain restoration. And here you can see the follow-up after 6 years. I want to call your attention to the maintenance of the papillary head position, the outline of gingival margin, and you can see here the new buccal wall completely remodeled and is still stable. And this is the follow-up after 12 years. Everything is being maintained in its original position. Talk about the gingival architecture position. If you make a comparison, the follow-up after 6 years and 12 years, what these two images have in common? We have the bone stability and height and thickness. So what are the keys to success in post-extraction aesthetic areas? The first key is the accurate diagnosis. Number 2, a traumatic extraction. 3, the 3D implant position. 4, the 3 millimeters gap at the facial aspect. 5, the 3D alveolar reconstruction. Number 6, immediate provisionalization that is directly related to the ideal emergence profile. Number 7, the thickness of soft tissue. Number 8, the selection of the appropriate abutment, zirconia abutment. The final porcelain restoration, and the last but not the least important is the thickness of the buccal wall. What we are looking for to have the tissue stability. This is what the patients are really looking for when they come to us in order to manage compromised sockets. So here we have the 6 different scenarios, very challenging clinical case. For those cases that we have the presence of the infection, the presence of the gingival recession, loss of the papilla, loss of the crystal bone, and loss of the buccal bone wall. And the question is, do you know a treatment planning simpler, faster, less invasive, more biological, more predictable, and less costly to manage this very challenging clinical case? This is the main goal of the IDR technique, to make it simple and predictable using this concept without in one single procedure, one single surgery without open the flap. I would like to invite you for the 4-day IDR experts. This is a global training. This is the 3-day theoretical classes plus 1 day hands-on. In the 1 day hands-on, my goal is to teach you the use of the cortical cancellous graft to restore 1 wall, 2 walls, 3 walls, or 4 walls around the condemned tooth, or the use of the triple graft in the management of hard and soft tissue damage for those cases that we have the combination between gingival recession and bone loss. And we also do live surgery in my 4-day IDR experts course. Very tough procedures. And here I'm performing the IDR technique. So we have already trained over 3,000 colleagues around the world. So during the 4 days, we have the lecture, discussion, the hands-on, and lots of interactive learning. My goal is to teach you in the easiest way possible how to manage compromised sockets and to allow you to apply this technique in your daily practice in the following day. I would like to invite you to come to Brazil this year, this November, from 25th to 28th, in my town, in my training center, in my IDR training center, in the southeast part of Brazil, in Caxias do Sul. In the same trip, we may have a very nice package, not only to come to me, but also to go to Rio de Janeiro and to enjoy the beautiful beaches in one of the most exciting places in Brazil, that's Rio de Janeiro. So if you decide to come to us this year, it will be a great pleasure to welcome in my country. I hope to see you soon this year at Rosa Education Training Center in Caxias do Sul in Brazil. Thank you very much for your kind attention and see you soon.